Bismillahirrahmanirrahim and good day everyone. I, Dr. Sadia Atta, welcome you all on board. Today the topic we are going to discuss is open bite, and then we'll be talking about the management of open bite and various etiological factors that are causing the open bite. So at the end of the topic we shall be able to know and recognize what an open bite is. We shall be able to develop an understanding of various types of open bite. We'll be talking about the etiological factors that contribute to the development of an anterior open bite and those factors that are contributing to the development of posterior open bite. Then we'll be talking about the management of anterior open bite and the management of posterior open bite that will be based on an understanding of the probable etiology. So starting off with the topic open bite. As I have already discussed, during the normal circumstances, this is the picture of a normal dentition. During the normal circumstances, the mandibular arch is overlapped by the maxillary arch. Here we can see that all the maxillary teeth, they are overlapping and covering the mandibular arch to a certain extent. This is an ideal occlusion. Whereas here in this picture, we can see that there is a lack of the vertical overlap. Similarly, we can see a lack of the vertical overlap here as well, and this lack is in this vertical dimension. Therefore, whenever there is a lack of vertical overlap between the upper and the lower dentition, particularly when the teeth are occluded, then we call it as open bite. So open bite is a vertical malrelationship, that is, it is happening in the vertical plane, and when the teeth are occluded, there are certain teeth that are not coming in their vertical overlap position. So we term this malocclusion as open bite. Now I'll be talking about the various types of open bite. There are various types of open bite. We'll be discussing them one by one. Firstly, I'll be talking about the anterior open bite. By anterior, we mean that these anterior teeth are involved in the creation of an open bite. Therefore, whenever there is a lack of vertical overlap between the anterior dentition, it is known as anterior open bite. When the posterior buccal segments are occluded, as we can see here in this picture, the posterior buccal segments are occluded bilaterally, and when they are occluded, there still is a gap between the anterior teeth and a lack of vertical overlap between the anterior teeth. This lack of vertical overlap between the anterior teeth when the posterior teeth are occluded is known as anterior open bite. Whereas if there is a lack of vertical development or vertical overlap between the posterior teeth, it is known as a posterior open bite when all the other dentition or all the other teeth are occluded. Therefore, in case of anterior open bite, there will be no vertical overlap between the anterior teeth, and when we talk about the posterior open bite, then there will be no overlap between the posterior dentition. Now, talking about incomplete overbite. In the normal circumstances, the lower incisal edges, these are the lower incisal edges, they come in contact with the cingulum plateau of the upper incisal edges in the palatal aspect, or they are coming in contact with the upper central incisors. In cases of certain malocclusions, for example, class 2, they are coming in contact with the palatal mucosa that is even lying behind the cingulum. Therefore, these incisal edges, the lower incisal edges, they are either coming in contact with the soft tissue of the palatal mucosa, or they are coming in contact with the upper dentition at any point of the upper dentition, maybe cingulum plateau, maybe anterior to the cingulum plateau, depending upon the type of malocclusion. But if, as we can see here in this picture, if there is no contact of the lower incisors either with the opposing dentition or with the soft tissue, then in those circumstances we call it as an incomplete overbite, and it also comes under the category of open bite. So those circumstances in which the lower incisors, they do not occlude with the opposing upper incisors or the palatal mucosa, when the buccal segments are in contact. Here we can see that the buccal segments are in contact and the lower incisors are making no contact with either the opposing dentition or the palatal mucosa. This type of malocclusion will be termed as incomplete overbite. So if we further go on classifying the open bite, then we further classify them as bilateral open bites and unilateral open bites. As the name suggests, by bilateral open bite, we mean that when the dentition is brought into closure, or when the dentition is in occlusion, the open bite is present on both sides. As we can see here in this picture, open bite on the right side and open bite on the left side. Therefore, if the open bite is present on both sides of the dentition when the jaw is in occlusion, it is known as bilateral open bite. Whereas if the jaw is in occlusion and the open bite is present on one side, as can be seen here in this picture, this type of open bite is only present on the left side. This type of vertical malrelationship is present on this side. This lack of vertical relationship when the teeth are brought in occlusion on one side is known as unilateral open bite. So till now we have discussed about what open bite is, that is a lack of vertical relationship. It can happen between the anterior teeth, it may happen between the posterior teeth, and then we classify it as anterior open bite if present between the anterior teeth, as posterior open bite if it is present between the posterior teeth, unilateral open bite if it is present on one side of the intraoral cavity, and if it is present on both sides, then we term it as bilateral open bite. So now we will be talking about the localized open bite. As the name suggests, if the open bite is present due to a single tooth or one or two teeth or a few teeth, then we will be calling it as a localized open bite. As we can see here, that there is no vertical overlap in this area of the canine. So this is a local area that is being affected by one or two teeth. So if the open bite is localized and it is caused by one or two teeth, it is known as a localized open bite. Now I'll be talking about the etiology of anterior open bite. Why anterior open bite? Because the etiology of anterior open bite and the etiology of the posterior open bite, that differs. So we will be talking about the etiology of anterior open bite and posterior open bite separately. As with all other types of malocclusion, there are both the inherited and environmental components that are contributing to the development of that occlusion. Same goes with the etiology of open bite. It is very multifactorial. Many factors are involved, and any of the given factor can be predominantly involved in the creation of an open bite. So firstly, we'll be talking about the anterior open bite. The etiological factors that may be involved in an anterior open bite are the skeletal pattern of the patient, soft tissue factors, habits, trauma, localized failure of development of certain teeth, and mouth breathing. So I'll be discussing them one by one. Firstly, we'll be discussing about the skeletal pattern. So about the skeletal pattern, the individuals who are having a tendency for a vertical rather than a horizontal facial growth, they exhibit an increased vertical skeletal proportions. By this I mean the individuals who are having a long face tendency are more prone to develop an anterior open bite instead of the patients who are having a low angle or a normal face tendency. Therefore, what happens is when the patient is having a long face tendency, is having a long face, the lower third of the face is increased. In those cases, when the lower third of the face is increased, it means that the distance between the maxilla and the mandible is increased. So whenever there's a distance, whenever the distance between these two jaws increase, the interocclusal distance increases. The interocclusal distance increases, which is to some extent compensated by the extrusion of the teeth, by the extrusion of the buccal segments and the labial segments. But if this interocclusal distance exceeds this compensatory ability of the dentition, if this interocclusal distance increases even more, then there is a tendency for the establishment of an open bite. By this I mean that if this distance of maxilla and mandible, this vertical distance between maxilla and mandible increase, to some extent the dentition is compensating for this increase by extrusions. But if this distance increases beyond their ability to compensate, then there is establishment of this open bite. So usually the open bite that is seen in cases of skeletal pattern of the patient, that is seen due to the skeletal pattern or because of the increase in the interocclusal distance, is a symmetrical open bite, which means that it is same on both sides, that the open bite is same on both sides. And in the more severe cases, what we can see is in those cases which are having a very long face or which are having a very high skeletal pattern, what we may see is that this open bite may extend distally till the molars, even to engage as we can see here, the incisors are not in contact, the lateral incisor, the canine, the premolar, the second, and then we can see that the contact is established at the molars. So it varies on the intensity of the open bite, that if the pattern, the interocclusal distance is way greater and the patient is having a very long facial tendency, so the open bite may extend distally till the molar or the premolar. So what happens is, when there is a tendency increase in interocclusal distance, the molars, they try to compensate, they erupt, though all the other teeth erupt, but the molars are erupting. And with this compensation, when these molars are erupting, they are further causing the mandible to go and to move downward and backward, that is further worsening the open bite. So this is what is related to the skeletal pattern of the open bite, in which we said that the patients having a long face tendency, they show the skeletal pattern, and usually we observe an anterior open bite in those patients because the teeth, they are trying to compensate. But if it is beyond their ability to compensate, then an anterior open bite may establish. Usually the open bite that is associated with the skeletal pattern is the symmetrical open bite that is present on both sides. And if there is a severe involvement of the skeletal pattern, then this open bite may extend distally up to your molars, or even having a single molar contact. Now, the second etiological factor of anterior open bite is the soft tissue factor. So now we'll be talking about the anterior oral seal. So what basically is that in order to be able to swallow, it is necessary to create an anterior oral seal. So whenever there is an anterior seal, then we are able to swallow. So in younger patients where the lips are not developed vertically, in those cases, we call them incompetent. If the lips are not meeting each other, we call them incompetent. But usually in the young patients, because the vertical growth of lips has still to happen, so they are mostly presenting with incompetent lips. So what happens in younger children, this anterior oral seal is usually achieved by positioning the tongue forward between the anterior teeth in order to make an anterior seal for swallowing. So what is an anterior open seal? A seal that is created anteriorly in order to swallow. So in younger patients, because the lips have yet not attained their complete level of vertical maturity, there's a certain degree of lip incompetency. In those cases, the tongue may be brought forward between the teeth to make a oral seal. But what happens in adults, that the lips have gained their maturity and the seal is made by the lips, not by the tongue coming forward. That is a usual and normal pattern of swallowing. The normal pattern of swallowing is what is the normal pattern of swallowing? The lips come together, make a seal, and then the patient swallow. So what happens in cases with increased vertical skeletal patterns, as we talked about it earlier, that usually in cases of anterior open bite, the skeletal pattern is increased. There's increased interocclusal distance. The maxilla and mandible, they are lying far apart from each other, so usually in these cases there is increased interocclusal distance and incompetent lips. Or the patients who are presenting with or the patients who are presenting with an anterior open bite, in those cases what happened is that the tongue has to come forward in between the teeth to make a seal for swallowing, because the teeth are not meeting each other. Here we can see sorry, the teeth, they are not meeting each other. Therefore, in order to make a seal, the tongue has to come in between to make a seal. So this type of behavior of the tongue to make a seal anteriorly in order to swallow because of anterior open bite, it is known as adaptive tongue thrust. That the tongue is coming forward to make a seal for swallowing because the incisors are not meeting each other. This type of behavior of the tongue is known as adaptive tongue thrust, and it is because of the anterior open bite, and usually it has a potential to revert to a normal swallowing pattern once the anterior open bite has been corrected. So by this I mean that because the teeth are not coming in contact and we have to make a seal, so the tongue will come forward to make a seal for that, for the swallowing purpose. And this coming forward of the tongue to make a seal in cases of anterior open bite is known as adaptive tongue thrust, and has a potential to revert if the anterior open bite has been is corrected. Up now here I would like to mention that there is a difference between adaptive tongue thrust and endogenous tongue thrust. What do we understand by endogenous tongue thrust is because the tongue is coming because there's a difference between endogenous and adaptive. By adaptive we mean that the tongue is adapting to the anterior open bite and making a seal, and by endogenous we should understand that the problem lies in the tongue itself, that because of the tongue and because of the continuous thirsting of the tongue forward, we may develop an anterior open bite. But usually it is very rare. The endogenous tongue thrust, it is also known as the primary tongue thrust, and it is usually very rare. But if it is there, it is very difficult to distinguish between an adaptive tongue thrust and a primary tongue thrust. So as most of the occlusal features they are presented with are similar. So if however there are certain suggestions that if an endogenous tongue thrust is there, then it may be associated with a sigmatism, and by sigmatism we mean lip sync. So here we are discussing the differences between endogenous and adaptive tongue thrust. Adaptive tongue thrust is a thrust that tongue is coming forward to make a seal because of the anterior open bite, whereas endogenous or primary tongue thrust is because of the tongue thrust there is an anterior open bite. Okay, so these are all endogenous tongue thrust is very rare, although if present it is very difficult to make a difference between these two, as all of the occlusal features are almost similar. The only differences that are suggested between an endogenous and adaptive tongue thrust are two differences. Number one, in cases of endogenous tongue thrust, it is associated with a sigmatism, and by sigmatism we mean a lisp. That the patient will be having a lisp when he will be talking. That lisp suggests that this thirst is primary tongue thirst or endogenous tongue thirst. Secondly, in cases of endogenous tongue thirst, the incisors, the upper and the lower incisors, they also seem flared or proclined, as can be seen in this patient. That the upper and the lower incisors are proclined by the action, by the repeated thirst of the tongue. The incisors are proclined in cases of endogenous tongue thirst. Now, another factor, etiological factor contributing to anterior open bite are the habits or the non-nutritive sucking habits that are associated. Now, what matters about habit is the duration and the intensity of the habit. So, by duration, if a habit is continuous for like 6 hours a day, or it continues till the mixed dentition, so that is the duration that actually matters. It's not about if a patient, if somebody is putting his finger or his thumb in his mouth for 1 minute, 2 minute, 1 hour, or once in a blue moon. It is about the duration and the intensity of the habit that matters. So a persistent the habit with a long duration is what actually matters and what creates an anterior open bite. So digit sucking habits that continues into the mixed and the permanent dentition, they may result in anterior open bite. And why are they causing the anterior open bite? So if a habit is persistent and the patient, for example, a patient is putting a thumb or a finger inside his mouth or her mouth for a long period of time, what it is doing, it is not letting the incisors to erupt. It is reducing the potential of the incisors to erupt. And secondly, what it is doing, because a thumb or anything is placed between the incisors, there is a gap between the posterior dentition. Therefore, the posterior dentition is uh, having a tendency to erupt. So there will be eruption of the posteriors and non-eruption of the interiors that will lead to the development of an anterior open bite. Secondly, what matters is, if the somebody is putting a thumb in cases of thumb sucking habits, and it is he or she is sucking it, so what is being established is a negative pressure inside the oral cavity, or the negative pressure in the maxilla. So that will lead to a creation of an anterior open bite with a posterior cross bite, because the maxillary dentition will be pushed inwards. Therefore, the non-nutrition sucking habits, they may cause an anterior open bite, and if they are also generating a negative pressure, they may create a posterior open bite. Now, the cases usually in the cases of habits, the open bite that is created is asymmetrical. That is not equal on both sides, as can be seen in this picture. So here the open bite is more, here it is less, depending upon what thing is used for the habit. For example, a thumb or a finger, and what is the exact position or location of the thumb or finger in your mouth. So normally in cases of habits, the anterior open bite that is produced is asymmetrical, in contrary to the symmetrical open bite that is seen in cases of of open bite in skeletal patterns. Whereas if the patient is putting two fingers together, so then in those cases the anterior open bite that is produced may be symmetrical. Okay. Now, when the digit sucking habit is eliminated or is stopped, the anterior open bite has the tendency to revert or resolve itself but partially, and it takes time, several months. But if in a small portion of cases where the habit has continued until the growth is complete, then the open bite may persist. So there are two different things. If the patient stops his habit early, and there is an open bite, there is a tendency that it may partially resolve, but still you'll be needing some fixed appliances or the appliance therapy to correct it. But in those cases in which the growth has been completed, in those cases it may be persistent, and appliance therapy is required to correct it. So here we can see, as I said, that in those cases in which there is a habit along with along with a negative pressure, that is thumb sucking, for example, there is an anterior open bite here, anterior open bite along with the posterior cross bite because of the negative pressure that is being generated. And here in those cases where we can see that the patient is sucking two fingers, in those cases it may result in a symmetrical anterior open bite. Now, another etiological factor that may lead to the development of an open bite is the localized failure of development. For example, one or two teeth, they fail to erupt completely, or there is some problem lying in their alveolus. Usually it is seen in patients with cleft lip and palate. As we have discussed in crossbite as well, that in cases of cleft lip and palate, the maxilla itself is deficient in all three planes of space, particularly due to the scar tissue that is formed or the cleft. So, if the maxilla is deficient in the transverse plane, anteroposterior plane, and it is also deficient in the vertical plane, so this deficiency near the alveolus of the cleft, the vertical deficiency is also there, which may result in the localized failure of development of the dentoalveolar complex of that of the area near to the cleft, which may result in the establishment of the development of a localized crossbite, as can be seen here and here in this picture. So the last factor that may be a etiological factor that may be involved for an anterior open bite is mouth breathing. So there are patients who are having any difficulty in breathing because of any nasal issues or nasal problems or nasal polyps or DNS. It may be certain adenoids because of which they cannot breathe properly through their nose, or enlarged tonsils. So in those cases of the patients who are having any difficulty or nasal obstruction, and they are having a difficulty to breathe through their nose, they have to put their mouth open and they have to breathe through their mouth. This breathing through the mouth is known as open or mouth breathing or open mouth posture. So if their mouth is open while breathing, what happens is the posterior teeth, they are free to erupt, which causes the mandible to, the eruption of the posterior teeth, which is causing the mandible to rotate downward and backward, hence worsening the anterior open bite. In those cases, there is increase in the lower facial third, incompetent lips, and anterior open bite may be established in those cases. So mouth breathing may also be contributing to anterior open bite. So till now we have discussed the etiological causes, in which we have discussed the skeletal pattern, the soft tissues, adaptive punctures, endogenous punctures, habits, localized failure of development, and mouth breathing. So last cause of anterior open bite is trauma. So whenever there is a trauma to the anterior dentition, there may be intrusion of certain teeth or the anterior teeth. As here we can see that there is a trauma and there is intrusion of this right central incisor, and there is a lack of vertical overlap. So what happens is, if it is a young patient and most probably the root, as we can see here, the root apex, there is not closure of the root apex, the root apex has still to be closed. So in those cases, there are times that there is spontaneous eruption and the tooth come back into occlusion. But if the root is the apex of the root is closed, or the tooth is avulsed and have to be cemented again, in those cases there are chances that ankylosis may establish. So in case of ankylosis, there is a lack of vertical development of the dentoalveolar complex in that area, which leads to the establishment of a vertical defect and hence a anterior open bite. Whereas in cases where there is not spontaneous eruption and there is no ankylosis, there can be either surgical repositioning of these teeth or can be brought orthodontically into the arch. So by now we have discussed all the etiological causes of anterior open bite. Now I'll be talking about the etiological causes of the posterior open bite, which varies from the anterior open bite. So usually what we see is usually posterior open bite is not very common, and the etiology is also very less understood, but still there are certain factors that may contribute to the establishment of a posterior open bite. I'll be discussing them one by one. The one of the major factors that may cause a posterior open bite is if we are going for the early extraction of the first molars. See, as we can see here, there is a localized posterior open bite over here, and early extraction of first molar may be a cause. And it is suggested that it may possibly occur because when the permanent molars are extracted earlier, there is a lateral tongue spread. So the tongue basically, it comes in this area which doesn't let the teeth erupt completely, therefore resulting in the posterior open bite. Or secondly, as we can see here, there first of all there is a lateral tongue spread. Secondly, there is a mesial tilt of the molar. When the posterior molar is it's coming forward, it is having a mesial tilt, which is resulting in this open bite. Therefore, the etiology of the first etiology of posterior open bite includes the early extraction of permanent molars. Secondly, if there are any infra-occluded deciduous molars, as we can see here, these are all permanent dentition. There is one ankylosed infra-occluded molar which is causing a localized posterior open bite. So if there are infra-occluded deciduous molars, they may contribute to the posterior open bite. Now the modality of treatment varies in them, whether these ankylosed deciduous molars are having a permanent successor or not, or whether they are having no permanent successor. So that is some other debate and some other discussion, so we'll be discussing them later. But till now, what we have to remember in the etiology is that infra-occluded deciduous molar may also contribute or towards the etiology of posterior crossbite. And other major contributing factor for the posterior crossbite are the eruption disturbances. Among the eruption disturbances of the permanent teeth are two most common eruption disturbances. First of all, the primary failure of eruption, and secondly, the mechanical failure of eruption. When we are talking about the primary failure of eruption, as we have discussed earlier, primary failure of eruption is genetic in origin. The parathyroid hormone receptor 1 gene is involved. All the teeth that are distal, see here, all the teeth that are distal to the first involved tooth will be involved. Therefore, if this first molar has not erupted, so all the other molars will not erupt. That will lead to a posterior open bite. Whereas in case of mechanical failure of eruption, if one tooth is having a mechanical failure of eruption, the teeth that are distal to it, they have the capacity or ability to erupt. And usually mechanical failure of eruption, it involves the first molars. Usually the mechanical failure of eruption, it is involving the first molars. And usually it is also having radiographical signs of ankylosis. See here, we can see certain radiographic signs of ankylosis here. See here, my pointer is not going over there. Anyways, I know you are getting the point. So in cases of mechanical failure of eruption, usually there are chances of ankylosis. The teeth which are posterior to them, they can erupt, whereas in primary failure of eruption, there are no signs of ankylosis until and unless we gave them orthodontic traction. All the teeth distal to them are also involved. So both the primary failure of eruption and the mechanical failure of eruption, both of them, they contribute to the etiology of posterior open bite. So lastly, the factor that is involved in the Posterior open bite is considered as a unilateral condylar hyperplasia. In case of unilateral condylar hyperplasia, what happens is there is excessive growth at one condyle. That is usually idiopathic in nature and involve girls at the late teens. So what happens in unilateral condylar hyperplasia, that there is excessive growth of one condyle, which leads to facial asymmetry and hence the development of mostly unilateral posterior open bite. So in these cases, if the problem is suspected, a bone scan is required, and according to the bone scan, the treatment plan is then executed. For example, according to the bone scan, you may be going for condylectomy or any mandibular surgical procedures. So this is all for today. We'll be discussing open bite and the classification of open bite tomorrow onwards, inshallah. So till now we have discussed what an open bite is, what are the various types of open bites, and what is the etiology of open bite. So what basically an open bite is the lack of vertical relationship between the upper and the lower dentition when the teeth are in occlusion. Then we said that there are various types of open bites, in which there is anterior open bite, posterior open bite, incomplete open bite, unilateral open bite, bilateral open bite, and localized open bite. After that, we discussed the causes of those open bite, in which we discussed the etiology of anterior open bite and the etiology of posterior open bite separately. Among the causes of anterior open bite are the skeletal causes. There are certain soft tissue causes, habits, trauma, localized failure of eruption, and certain mouth breathing habits. Whereas when we talk about the etiological factors that are contributing to the posterior open bite, these are the unilateral condylar hyperplasia, the eruption disturbances, and the problems in the permanent dentation, that are particularly the mechanical failure of eruption and the primary failure of eruption. Then we discussed the infraocclusion of the ankylosed primary molars and the early exfoliation of the molars. That's all for today. Stay home, stay safe. Allah Hafiz.